Thank you for viewing this webinar. My name is Dr. Ngiu Chai Soon. I'm a gastroenterologist and consultant physician with Cardiovascular Sentral Kuala Lumpur, CVSKL, at Jalan Sentral 5. So today's webinar will be entitled Chest Pain from a gastroenterologist's perspective. We know that chest pain is a very common complaint when patient came to emergency department or to the primary care. And we also understand that chest pain has a wide range of diagnostic probability. From physician's perspective, it poses a diagnostic challenge, and a wide array of diagnostic probability can be happen. And for a patient's perspective, they are worried that whether this is can be a life-threatening situation, or am I having a heart attack? And we also understand that in America, chest pain is the second most commonest complaint to the emergency department after gastrointestinal related complaint. And in primary care, we know that 2 to 4% of the presentation are genuine acute coronary syndromes. And most of them are actually a non-cardiac presentations, whereby musculoskeletal causes is the most commonest, and this is followed by gastrointestinal complaint, which is around 10 to 20%. Now we come to the topic of non-cardiac chest pain, which is the topic of discussion today. And what is non-cardiac chest pain? There's various type of definition for non-cardiac chest pain. First one actually is a recurrent substernal chest pain that is very difficult to distinguish from ischemic heart-related pain after a reasonable cardiovascular workup have been performed to rule out coronary artery disease. Another type of definitions of a non-cardiac chest pain is chest pain that is a non-angina in origin, which means that it's not precipitated by exertions and is not relieved by rest. And besides that, this is also not a type of chest pain due to ischemic heart disease. And the symptom of a non-cardiac chest pain can vary from squeezing or burning substernal chest pain, and it may or may not associated with any radiation. And the problem arises when the patient also have a concomitant cardiovascular related risk factors such as diabetes or high blood pressure. And we also understand the prevalence of a non-cardiac chest pain in the community setting can go up to around 33%. And there's no sexual preference in this type of complaint as well. We know that the risk factor for the non-cardiac chest pain are number one, which is the overweight, followed by acid reflux diseases, smoking, NSAID usage, so either is a painkiller or aspirin, patient who's prone to anxieties. And we also understand that the natural cause of a non-cardiac chest pain is quite benign. And this one study shows that out of 800 over patients that were studied, only 0.3% of patients actually have experienced death. And all these deaths are actually non-cardiovascular related. However, the significance of this condition it impacts on the patient's quality of life, and it also causes economic burdens to the patient as well. Now we come to gastroenterologist's perspective on the non-cardiac chest pain. And we're going to discuss about how we're going to investigate this condition. First, we look at the etiology of esophageal chest pain. Most of the time, the pain is due to acid-related reflux disease, and this can go up to around 50%. And we also need to consider other non-reflux related esophagitis, things like eosinophilic esophagitis or drug-induced esophagitis. And other factors they need to consider are more of a functional GI disorder, things like esophageal hypersensitivity or functional chest pain. And the other thing that we need to consider is primary esophageal motility disorders. So how do we take about the history in a patient with a non-cardiac chest pain? In terms of gastrointestinal related, patient may experience also retrosternal pain or heartburn. They may also complain of a difficulty in swallowing or painful pain during swallowing. And some of the patient may have effortless regurgitations of food back to their mouth. This is what we call a rumination. Rumination. And besides that, from the history taking, we need to emphasize whether the patient uses certain medication that known to have or to cause esophagitis. Things like antibiotic, tetracycline for treating acne, painkillers, NSAIDs, and some medication mainly for treatment of osteoporosis, things like bisphosphonate, also can cause esophagitis. And besides that, we need to take about the history of atopy, whether there's any allergies or not. This is more in relation to eosinophilic esophagitis. And the most importantly, we need to emphasize on the red flag symptoms. What are the red flag symptoms that we need to worry? Because these are the pointers that tell us the patient need a immediate or urgent endoscopy procedure. Things like patient who presented with dyspepsia after the age of 40 years old, any evidence of a gastrointestinal bleeding, the patient may present with a dark stool or melena, patient who their investigation shows iron deficiency anemia, patient who's experiencing loss of weight or loss of appetite, difficulty in swallowing, or painful swallowing. These are the symptoms that tell us the patient need an endoscopy as soon as possible. And besides, some other pointers of a red flag is when the patient's family member also have history of gastrointestinal related cancers, such as esophageal cancer or stomach cancers. Now we come to gastroesophageal reflux disease. We know that the PPI is recommended is first line when esophagitis is suspected. And how to diagnose GERD at the primary care level? So we can consider either the use of empirical therapy, which is the use of a low dose PPI with a longer duration of around 2 to 3 months, or we can consider something called a PPI test. PPI test is usage of very high dose of PPI in a very short course duration, which is up to a month. And various studies have shown that this type of test also has a good sensitivity, which can go up to around 80%. And besides that, this type of test also actually is quite economic for the patient. But however, when the patient doesn't respond to proton pump inhibitor, then we may need to consider about the use of endoscopy procedures already. Endoscopy is quite useful in terms of determining the mucosa and structural deformity in the esophagus. And then most importantly, we can take biopsy to ascertain whether there's any presence of esophagitis. And in the some other the newer development that we can consider is to perform a mucosa impedance if there's such tests available. Other tests that we need to consider is to do esophageal motility testing, and decide add on is to do the ambulatory pH monitoring for the patients. Now we come first to the endoscopic procedure first. And we found that statistically, that 44% of the patient may have a normal endoscopy procedure. And we found that actually endoscopy is not a very good test to determine erosive esophagitis because only around 20% of the patient may have such findings. And besides that, for the patient who has non-cardiac chest pain, some of them may have abnormal eosinophilic infiltrates in their routine esophageal biopsy. And we understand that this does not tell us that patient has eosinophilic esophagitis because eosinophilic esophagitis, if we investigate under a microscope, they will have more than 15 of eosinophils infiltrates. What are the expected findings of esophagitis? During the endoscopy procedure, we are looking for whether there's any presence of erythema at the gastroesophageal junctions or any ulceration changes. And most of us use Los Angeles classification to grade the reflux esophagitis. Other findings that can pinpoint to other conditions such as ulcerations in the esophagus, dilated esophagus in achalasia, or corkscrew esophagus in distal esophageal spasm. But as I mentioned earlier, that only around 20% of the patient will have endoscopic positive findings. So if the patient have endoscopically negative, so what should we do, especially when the patient still experience pain? Well, conventionally, we can consider barium swallow. Barium swallow can tell us that whether the patient has any motility disorders, such as achalasia or distal esophageal spasming. Of course, it also can tell us that whether there's any end organ damages from the esophagitis if it's shown already in the endoscopy. So if the endoscopy is unremarkable and the patient still experiences the pain, so what should we do? So first we can consider to do a barium swallow if we do not have high resolution esophageal manometry or pH study. And what's the benefit of barium swallow? So how do we proceed further if the endoscopy is unremarkable? The conventional test that we can consider to do is the barium swallow. This is a very old study, but what's the benefit that we can gain from barium study? Well, we can see whether there's any esophageal motility disorder such as achalasia or distal esophageal spasm. Of course, barium swallow also is good to tell us whether there's any end organ inflammations such as esophagitis or ulceration or any cancerous changes from the newer age already. So we need to consider things like high resolution esophageal manometry or the use of ambulatory pH monitoring, which is either we use a probe base or virus base. First, I'm going to discuss about esophageal high resolution manometry. Well, actually, nowadays, this is the current gold standard in investigation of esophageal motility disorders. And we have this, something what we call a Chicago classification. Currently, it's already entered version 3.0 that used to determine either major or minor motor disorders of esophagus. During the high resolution manometry, we can consider to do some propagative tests to, in case the high resolution manometry also give normal findings. So we can test the patient by asking them to to perform something called a meal test or a large volume water test. Sometimes these sort of tests can provoke the patient's esophagus and cause pain or discomfort and give rise to the diagnostic findings. So now I'm going to show you some images about the findings from the high resolution esophageal manometry. So we can see here that if you look at the upper left, we can see that there's something called no pressurizations. So the upper three changes are suggestive of achalasia, and the bottom two changes are suggestive of esophageal outflow obstructions. Sometimes these symptoms can cause a heart pain or chest pain-like symptoms. And if you look into the previous textbook, then maybe you can recall something called jackhammer's esophagus or a nutcracker esophagus. And we can see here that in these two images that actually they are very reddish in color. This means that the esophagus is highly pressurized, suggestive of a jackhammer's esophagus. And now we come to the ambulatory pH monitoring. So there's two types of pH tests. Either the patient's, either we connect the virus probe to the patient's esophagus endoscopically, or we can introduce a nasal catheter that can both measure the impedance and the pH readings from the stomach and the esophagus. So what is the benefit of ambulatory pH monitoring? So we need to discuss about whether this is a pH-only catheter or virus pH monitoring, because there is a pro and cons for these two instruments. If we talk about pH, probe-based pH only, they can only measure about the whether there's any presence of acid reflux and only up to 24 hours. Virus pH actually give a standard time of monitoring of the reflux that can go up to around 48 hours, and we can see that there is around more than 10% gain in the diagnostic probability. And besides that, a 21% gain in the subjective reporting of the patients as well. But the prop-based, for me, personally, I would prefer a prop-based test because we can perform impedance. Because this can help us to determine whether the patient has acidic reflux, non-acidic reflux, or weakly acidic reflux. Because we understand that when the patients, when we give a PPI to the patients, PPI helps to reduce the pH level of the stomach reflux, but it doesn't remove the reflux capability if there is a presence of a hiatus hernia. And this is a diagnostic algorithm to differentiate what is a functional chest pain, functional heartburn, or reflux hypersensitivity based on the ambulatory pH monitoring by usage of a impedance catheter. And nowadays we understand that actually functional chest pain or functional reflux disease actually is a spectrum of disease. Some of the patient may have some patient may have a lot of acid exposure, some will have a very minimal acid exposure, and some of the patient, basically their esophagus is very sensitive towards the acid. So this is the benefit of using a pH catheter to determine the types of reflux. And to the area of wrongful classification of functional esophagus disease, we know that some patients will have a very sensitive esophagus. Even a normal reflux for a normal person, the patient may perceive that as painful. And this type of situation can only help to be diagnosed by usage of a pH impedance catheter. And some other tests that can determine the hypersensitivity esophagus are such as the acid perfusion test, or we can use to have this thing called a tensilon test. And some of them we can use a balloon distension test to determine whether the esophagus is sensitive or not. Of course, now we come to a newer area already. So what are the other new tools that we can use? Before we go upon that, so we need to discuss there's something called dilated intercellular space in the patient who has acid reflux disease. Unfortunately, this type of investigation require esophageal biopsy that examine under an electronic microscope, which is not commonly available. But what are the technologies that can derive from this information? So there is something called mucosal impedance testing, and we know that patient who has a significant acid reflux, even though it's not present endoscopically, but the impedance level can be lower in this type of patient. Well, these tools currently is still at the investigation, more of a scientific research at the moment, and it's not commonly available. And some other tests that can help to determine the structural or mechanical functions of the esophagus are something called a functional luminal imaging probe that can be used to look into the pain of the patient as well. So again, when everything is negative, so we need to consider about functional esophageal disorder, whether it's functional chest pain, functional heartburn, or reflux hypersensitivity. And based on these classification, then we can treat the patient accordingly, either by usage of neuromodulators based on the patient's condition. So to end my discussion today, I would like to illustrate a case about an old gentleman previously I saw this patient. So my patient actually is an 85 years old gentleman who experienced persistent heartburn and chest pain for many years. And the patient actually was given a very high dose of PPI, Nexium, and he also was being a trial of proton kinetics as well. However, the symptoms is always persist and never resolve. And over the years, he has numerous workup, such as upper GI endoscopy performed. He also have lots of CT scan, CT coronary angiogram, CT thorax performed, just to determine what is the cause of his chest discomfort. However, all these tests were negative. And then subsequently, when I saw this gentleman, so I performed a 24-hour pH study after after I have stopped his PPI for more than a week. And basically, what we can see here, this is a 24-hour tracing of his reflux study. We can see here that actually there is not many reflux episodes. And besides that, based on the patient's symptoms also, he doesn't actually complain of much symptoms as well. And then when we determine his Demister score, actually his Demister score actually is very low, only 0.8. And we also notice that he doesn't have much reflux episode during the study as well. And his probability of having a GERD actually is none. And besides that, this patient will also proceed with the high resolution esophageal study. And from this study, it shows that this patient actually is having a distal esophageal spasm based on his delay latency of less than 4.5 seconds as shown in the image. When I performed barium swallow for this gentleman, actually it shows that he has a distal esophageal spasm, which is quite concordant with his high resolution esophageal manometry. So what is the treatment that we gave to this patient? In view of the age of more than 80 years old, so initially I tried with the usage of a calcium channel blocker. However, it doesn't really alleviate the symptoms. And then subsequently, after discussing with the patient, we proceeded with a Botox injection to the lower esophageal sphincter, and the symptoms resolved. Currently, he still come back on and off for Botox injections based on his symptoms. So I'd like to end my slides with a few conclusions. So basically, this slide shows the diagnostic algorithm of managing a patient who presented with a non-cardiac chest pain. And in terms of approach to a patient who presented with chest pain, always think about cardiovascular disease first. And the commonest non-cardiac chest pain, as I discussed earlier on, is the musculoskeletal causes, and followed by the gastrointestinal, which is the acid reflux disease, the commonest cause of a non-cardiac chest pain in terms of a gastroenterologist. And for general practitioners, so I think when you see this patient, after you determine that they do not have chest pain, you can give them a trial of a PPI first. I think this is quite economic to do so. But however, if the patient has a normal endoscopy, so you may need to consider about esophageal functional testing. With that, I thank for your attention. Thank you.